got the Breakthrough Alliance's board member and the chair of the Breakthrough Alliance Europe, Laurent van Lerberghe, and he's going to be interviewing one of the startups, one of the emerging technologies. They are early revenue. They are scaling quickly and successfully, and being led by a veteran startup specialist, Robert Rodriguez. And really happy to have Laurent and Robert on the program to talk about the significantly adopted and growing quickly platform HelixVm. Laurent, how are you?
You hear me? I'm very good, Stan.
That's fantastic. And Robert, can you hear me as well?
I can hear you. I hope you can hear me.
Yes, we just need to see your video.
Okay. Well, the machine is asking me to start the video, so hopefully you have the video.
All right, you guys are good to go. Handing it over to you, Laurent.
Yes, so moving from a clinical trial and diagnostic to actually medical practice. Robert, it's great to have you on these session together.
Thank you very much. Excited to be here.
Maybe we can start actually for those who don't know HelixVm well, and they should actually get on the website and know more. Can you basically tell the audience what HelixVm activity is about, and maybe a little bit more about your innovative technology?
Okay. What we are is basically a platform, in essence, to that's connecting patients and doctors through what most people would call telemedicine. But we brought a fairly big different wrinkle to it, which is that we're pioneering the use of asynchronous medicine with doctors and patients on the platform. So obviously, most telemedicine is, for the most part, synchronous, right? You get a doctor on the camera, and you get a patient on the camera. Well, our goal is to disassociate those two, so that way both patient and doctor can do their work individually at separate places and separate times, while at the same time being able to deliver what would be a billable medical visit for the patient, or for the doctor. And so it's different. The workflows are different. And that's what we've been building now for the past 3 years. In essence, a platform to solve that problem.
And as we think about these asynchronous, let's say health delivery, it sounds obviously feasible, easy, and let's say under control. Maybe today, can you share a little bit about maybe the steps you went through to fine tune and get a working, let's say, a set of activities?
Well, everything is a work in progress. So, but basically, this started with COVID, where we had situations where both patients and doctors didn't want to see each other. Everybody was a little scared. They wanted to sit at home and continue to live their lives, but not in essence exposing themselves. So what started out as, in essence, a demand and supply problem, in essence, morphed into an opportunity to take advantage of. And it's not necessarily new. The concept of asynchronous medicine is common. It's called sometimes store and forward if you look into the literature. But there's a long way to go, because you have two adoption curves, one for the physician and one for the patient. And so as a result, getting patients accustomed to, in essence, a self-service model, when they're much more accustomed to being essentially babied through a process. And pretty much the same thing for the doctors, right? The doctors are accustomed to many times doing their own observations, their own due diligence on a patient before treating a patient, getting them comfortable with the fact that you don't have to see the patient to do medicine. There is a good adoption challenge on both sides. And the key to working that and making this model work is, in essence, basically education on both sides, but definitely probably more so on the physician side, because it is a very different way of working for them.
And how do you manage, or how do you work on the combination of personalized care while it's asynchronous?
Well, on the patient side, one of the things we obviously do is our self-service platform allows us to do everything from get the patient's name all the way to doing, in essence, triage on the patient. In addition to that, what we do is we bring in third-party data, objective data, that exists out there in order to sort of populate a chart, and also populate an administrative chart as well as a medical chart. Being able to get all of that information it's a heavy lift. And then the second part is being able to then synthesize that information for the physician, so that way the activity of the physician is, as best as possible, an act of reading and analyzing. So that way they're not spending a tremendous amount of time doing data collection, and to some degree simplifying the analysis using AI tools to do decision support for the physician. So there's a heavy element of technology, both in terms of acquiring a lot more data than maybe historically you would be able to collect, and then also synthesizing that data for the physician.
And in this journey, can you maybe share some of the moments or triggers that really accelerated your development and brought you where you are here today?
Yeah, I would say that seeing patients is really what accelerates development, because sitting around on a drawing board, imagining this, or maybe looking at other websites that do similar stuff, or other companies, doesn't quite cut it. The service experience to a patient is what drives us, and what really is acting right now as our innovation engine. So, for example, simple things like, simple things that people kind of take for granted, which is, how do you verify that a patient is a patient and that the information that they're giving you is correct? It's a monumental task. And if you don't do it the right way, financially speaking, you can take tremendous losses as a medical provider. On the flip side, with respect to physicians, not everything the patient tells you is the truth. And at times, being able to get objective data from third parties, license holders, in essence, really helps to validate your ability to process that patient and to give service to that patient. So, we've seen, I think, about 50,000 patients over the last 12 months. We're going to continue to grow. And I think that those service experiences in terms of patients, making sure that we can manage the whole cycle with them, and also giving physicians, in essence, an extract that allows them to read and, in essence, treat without having to do all of the glad handling that typically comes with inpatient, in-office type work.
And do you get actually feedback from patients on not in their visit, but more like on the tool, the software, the technology, and how do you actually integrate it in your improvement development cycle?
Interesting enough, we did a study with HITLAB with respect to the usability of the platform with the patients, and I think that the feedback from the patients, I think it really does need to be divided into, I think, sort of three pieces. The feedback usually comes in the form of, hey, I don't understand why I need to give you this information. And so that's really more of an administrative task in terms of user feel and making things as easy as possible. So we work on that every day. The second part is, in essence, why am I being asked all of these questions? All I want is X. And so as a result, there's an aspect to, in essence, simplifying triage and constantly focusing on minimizing the baseline questions, as well as also working on the AI in order to make it much more efficient as a decision support tool. And then the last piece is money, because I mean, in the States, there is a significant financial component to every patient you see, and for the physician to get paid. And there's definitely a lot of noise around that, because at the end of the day, I don't think I've ever met a patient who wants to pay for healthcare. And so, but at the end of the day, if they don't pay, the physician's practice certainly struggles a great deal. So working with different, insurance companies, payer arrangements, and patients without insurance, there's a lot of feedback there, and some of it some of it nice, some of it quite nasty, frankly. So they tell you when you don't meet their expectations, and they tell you pretty loud.
And in terms of care, I mean, what segment of care are you covering, and then planning to cover? And can you cover them all, from like day-to-day to emergency, or maybe some more severe specialty care areas?
Yeah, the range of care for the platform, I would say we get three types of patients. The first is what I would call the typical urgent care type patient. I think I have a cold and a flu and I need something. Typically an antibiotic, maybe some pain or a steroid. The second piece are patients who are seeking gap care because they have a prescription that has to be renewed and they can't get in touch with their physician. So those two segments, which are relatively simple medicine, are the biggest sources of patient count for us. And then we do have about 20% of the patients who come in with what I would consider, general medicine. Typically, I don't feel well. I mean, we've seen all types. We've seen patients come in with, belly aches and need to go to the hospital. Patients who, come in who are looking for surgery, and we're not sure how we can help you do that. But there's a wide range of medical seekers who end up in our platform. But most of it is what I would consider low-hanging fruit medicine, which is gap care and typical emergent care, simple emergent care.
And in your development, what are the challenges in terms of scaling up? I mean, you were talking about 55,000 patients, if I'm correct.
Yeah, over 50.
What are the plans and maybe the obstacle or milestone you see as you gotta scale it up?
Well, we've made every mistake. We've banged our heads against the wall, which is kind of how we learn. We learn through making mistakes. But I would say, our scaling imperatives first and foremost is that we've got to migrate our technology platform to sort of a full cloud architecture in order to meet patient expectations on latency related issues. That's part one. The second part two, is we have to get more sophisticated in terms of the triage. So that way we don't spend as much time with the patient asking necessarily unnecessary questions, but only ask the ones that are most relevant to their condition. So imagine, that you have 15 common conditions, with potentially 250, 300 different outcomes, and you have to be able to sort of model all that. So we've started that process. And I think that those two things are probably the most important in terms of scaling, in terms of customer acquisition and retention. I think that the latter part of it is just making sure, because physicians are still involved in the process, that we are building a physician team that understands where we're going and what we're trying to do, which is we're trying to change your workflow to be, instead of 100%, face-to-face medical encounters, to maybe something along the lines of 70% asynchronous, 30% face-to-face. And clearly that would change by different specialties. I think, the more complicated specialties, allergy, immunology, et cetera, obviously it's a little bit more complicated, but, we're definitely for, primary care, urgent care, family practice type stuff. I think we have a pretty robust solution that we have and we're building further.
In terms of geographical focus, I mean, is it a solution that can expand US wise and maybe even internationally? Or because of some of the elements you mentioned, it's more like state-wise or more limited geography?
Yeah, the application right now, I mean, we're a consumer adjacent platform. I mean, everything is about the consumer and the doctor. Okay, so we're not just a pure let's do something more efficient for a physician's practice. So and the U.S. service experience is a little different for a consumer than it is in other countries. So we've started with the U.S. consumer service experience, pretty much focused on the U.S. market at this moment in time. We do think that in the future, as we develop the platform and some of the microservices that are inside the platform, that there is an ability to cherry pick some of the services, particularly in the area of physician workflow and the integration of asynchronous medicine into a practice that can be, in essence, licensed on an international basis. But we got to start small and work our way big. So, and sick people are sick people, and we have plenty of them here in the United States. So we got to start.
Yeah, super interesting, Robert. But maybe as a word of conclusion in the last minute, any word of advice for people here listening to us? Probably not to set up a similar company, because obviously you don't want to multiply a competitor. But as they set up their digital health solution, advice on getting on the journey like you?
Well, I could be a little biased here, but I'm a very strong believer in, at least for US based solution, that you want to have people who understand the US healthcare system. I mean, you can have the most brilliant technical mind, but if you don't understand the culture of how medicine is delivered in this country, if you don't understand the legal issues, I think that you're liable to work on something really cool that doesn't quite fit the profile. So I believe that experience and working with your customers, very closely with your customers, and taking all the lumps that comes with it, I think is super critical in order to even have a chance of getting out of a startup mode.
Super. Thanks a lot, Robert. And for those listening here, please connect on LinkedIn with both of us. Follow up with any question. Obviously, we're available. Looking forward to continue the dialogue. Up to you, Stan.
That's fantastic, Laurent. Thank you. And Robert, one question for you before you sign off. I just wanted to know, again, into the audience here today, this is one of the organizations, this is one of the technologies that the lab has identified through multiple studies as very adoptive and adopting quickly. And Robert, if there is a person or people in the audience who would be your best customers, who would those people include? What organizations would they be from?
Well, there are a few verticals that we're focused on today. I think the first is, obviously we're going direct to consumer, but to me, a provider organization who's looking for like an ED diversion program where they're trying to get simple medicine out of their emergency room, which clutters them. And they can continue to still bill the patient, but we would in essence provide the platform to process and diagnose and do all that work. So I think ED diversion, and I also think that on the pharmaceutical side, the folks who are looking to go direct would benefit with a consumer-oriented solution that helps link the authorization process to the patients that they're marketing. I can't believe the billions of dollars that are spent on advertising, and they don't know where those customers are going. You might get interest in the customer goes to a doctor and they go somewhere else. So in terms of what they're buying. So I think linking, consumer marketing efforts to actual authorizations and real patients that can be funneled into the distribution network that they have, which are professional distribution networks, obviously.
It's fantastic. Well, thank you again for joining today.